All right, good morning, ladies and gentlemen, and a very warm welcome to all you lovely people who are watching us live from various parts of the globe. My name is Ruben Lobo, and on behalf of Team DentistChannel.Online, I warmly invite you to the 7th day of the biggest virtual implantology event of 2020. Ladies and gentlemen, this morning we have with us a very special speaker. Allow me to introduce him in length. Usually, I try to cut short on the introduction part. But when it comes to Dr. Akshay Bhargava, I believe introducing him in length and for the kind of achievements he's had only makes me proud, makes Dentist Channel proud, and I'm sure it will all make you proud as well. So please allow me to introduce Dr. Akshay Bhargava right from the first point to the very last point. I'll try to do that as soon as possible. Dr. Akshay Bhargava currently is the Dean of Santosh Dental College and Hospital. He is professionally a prosthodontist and implantologist, a teacher, a motivational speaker, an entrepreneur, as well as a scientist. Professor Dr. Akshay graduated from Bapuji Dental College in the year 1992 and completed his master's degree in prosthodontics, including crown bridge and maxillofacial prosthodontics in the year 1995. Dr. Bhargava is an associate fellow and an active member since the year 2012 of the coveted American Academy of Implant Dentistry, Chicago, USA. He holds a double diplomate from the International College of Implantology, USA, and the World Congress of Oral Implantology, Japan. He is also a fellow of the International College of Dentists, which is based in USA. He is a postgraduate teacher with 25 years of academic and clinical experience. Currently, Dr. Bhargava runs his private practice, Rahat Dental Clinic, with Dr. Renu Bhargava in Dwarka, New Delhi. He conducts motivational and educational programs for all professionals from the field. Like I said, he is the Dean of Santosh Dental College. He was appointed as a scientist for the development of the indigenous dental implants in Defense Research and Development Organization, DRDO, Government of India. Dr. Bhargava, after working as a teacher for undergraduates and postgraduates in various institutes, was appointed as the head of the Prosthetic and Implantology Department at ITS Dental College, where he taught and conducted various implantology and prosthetic courses for 12 years. Professor Dr. Akshay has been the Dean, Professor and the head of the Department of Prosthodontics for Faculty of Dental Sciences at SGT University, Gurgaon. He has been the Director, PG Studies and Principal at ITS Dental College, Greater Noida till August 2018. He has to his credit more than 2 dozens of research and publications. On ResearchGate, Dr. Bhargava has 85 citations and about 2,600 reads to his publications. He is a contributory author for 2 leading dental material textbooks, that is the Notes on Dental Materials, which includes authors like Dr. V.K. Subbarao, and publishers are G.F. Offset, which was published in the year 1996, as well as Basic Dental Materials under Dr. John J. And the publishers were J.P. Brothers Medical Publishers Limited. He has guided more than 60 research studies, including projects from the Indian Council of Medical Research related to zirconia implants, dental materials, biomechanical and structural analysis. In recognition to his contribution to International College of Dentists, Dr. Akshay was conferred the prestigious Dr. Ratan H. Memorial ICD Section 6 Award in the year December 2014. Ladies and gentlemen, presenting to you Dr. Akshay Bhargava live.
Hi, Ruben. Thank you so much for the warm introduction. Can I have my slide share or should I do it on my own?
Yes, sir. You can do it on your own. Thank you.
Okay, friends. Very good morning on this warm, rainy Sunday in India, in Delhi. And a pretty offbeat topic that I've taken, surface treatment of implants. Now, you see, my last topic of speech was the progressive loading and loading protocols. And generally, I feel that this is a particular topic that we, as clinicians, probably don't like to read much or get to know much, because this is generally done on the side of the manufacturer, and whatever is being told to us and claimed to us, we believe in it. However, by the end of my presentation, I hope I can probably bring a few insight thoughts into you as to how important this particular topic is, the topography of the implant, the kind of cases where you use, the type of bone where you want to use, and the surface treatment, how it basically is going to change the outcome of the clinical scenario when you work. So here we go. Thank you so much, and let's begin. Does the implant surface and its design really affect our clinical outcome? Is it that we put anything? You know, we have cylindrical implants, you've got threaded implants, you've got micro threaded implants. Is it really that important? You have platform switching. So, well, we all feel, yes, to a certain extent, things are there. If you go back in 1968, when Dr. Per Ingvar Bredemar brought his uh, implant first into the market, it was a smooth collar. The collar was around 2 to 3 millimeters of smooth collar, where we believed into the fact that, the smooth collar is going to help in the attachment of the periodontium. So we will discuss all of these factors, and today we have micro-threaded implants and platform switching. So these are the few changes that have occurred, and we are going to discuss this. And gradually we are going to build up that how exactly is the surface texture and the implant design important. Let's look at a review of literature. We have a few nice research work done by Indian authors, and he's Dr. Major Amit Bhandari, where he's brought a review article on effect of surface design and morphology and primary stability of dental implants. See, primary stability. They are not talking about anything else but primary stability. We are not talking about osseointegration, because that's going to happen after another 52 weeks or 3 months. So primary stability of a dental implant. And what do they say? The results showed that the implant, the red box that we have over here, but if you have long implants, wide implants, more thread, you get better primary stability. And when micro designs, you talk about calcium deposition through sandblasting, provides good results. Now, this is one aspect. And let's look at another study, an effect of thread design on neck, preliminary results. You have discrete calcium phosphate nanocrystalline deposition. Now this is nanocrystalline. It's a surface treatment which enhances osteoconduction on titanium-based implants. Implant thread designs, again by Dr. Suresh Sajjan, Chandrasekhar Nair, and Yenumula. Good overview where I would suggest all of you to read these articles to get an insight on how exactly the designs make a difference. Before we proceed further, a brief introduction, because these terms are going to come in our discussion. And just to explain, you see the crest of an implant, the root of an implant, the helix angle, the pitch, and the lead. You see, these are the basic gross macro topography, which you could say is the actual geometry of the implant. The crest is the outermost surface joining the two sides of the thread. You can see the arrow over there, the most outermost side where the two threads come out. This is the maximum diameter of the implant. Root, the innermost surface joining the two sides of the thread. Helix angle, I will explain probably later. It's the angle formed by a point on the side of the plane perpendicular to the axis of the screw thread. If I take a long axis from here, the angle formed by the thread face is the thread hex angle. This actually gives you the cutting edge. Pitch is the distance from one point of the thread. You see one point of the thread to the other point of the thread. This is the pitch. Now we all understand if there are more threads, more surface area, more cutting efficiency, but does that also lead to a better load distribution? So let's discuss this. And of course, the lead is the actual distance that the implant advances in one complete turn. The thread pitch and lead are the same for one start implants. Now this is a terminology where people say if you buy an implant which has one thread and you just give it one turn and it will go in one. For multiple start threads, the lead is a multiple of the pitch. If you have 4 threads in this particular direction, the implant will move 4 times more into it. So way back in 1995, even I did a study on the effect of, three-dimensional screw-type end-osseous cylindrical implants, the effect of design variability, where we check the length of the implant, the width of the implant. And I want to bring to your attention that this is not now, this is long time back, 1995. And because these were done for the DRDO implants, which are now, of course, in the market. And it got them the license for the from the drug controller. Now, FEM studies are important for them. In 1995, we got this conclusion that the maximum stresses are seen in the cortical layer at the neck of the implant. Vertical forces are not critical, and implants can take these vertical forces. Anterior forces, anterior posterior forces are most unfavorable. That means the lateral stresses. So application of stresses in three dimensions results in formation of a resultant vector, which leads to a stress concentration in the region of the resultant vector force or area, and this resultant force is generally around the neck of the implant or the apex. So I'm talking in 1995, these things still hold true, and we are still into the same way that how the design of an implant is going to make a difference. Of course, we also studied the length and width of the implants and its effect. So if I look at other work that have been done and how things make a difference, you can see over here, way back in 84, Roberts did a study. Now, this is basically effect of thread pitch. I told you the distance between two threads is the pitch. Now, this V-shaped threads, they create a higher bone to implant contact. This is what they found. Now, we are going to also discuss the types of threads we have. So just an introduction. That is why I showed you a diagram that if you have a V-shaped thread, this is basically how macrogeometry is affecting our, clinical outcome. If you look here, that the Brennemark 0.06 mm pitch machine surface with 0.5 mm pitch, thermally oxidized surface with 0.1, they found natural cortical bone and cancellous bone when you place it. The results were that a 0.6 mm pitch had more crestal bone loss then a 0.5 mm pitch. Now you see, just with 1 mm pitch, they are finding in a machined implant. Okay. Now, if I surface treat this, the results are totally different. So, just an insight into how the design actually affects the outcome of implantology. This was a small introduction. And of course, this is the crest of the module. If you see the crest, if it is micro threaded, like we have all implants today, unlike what we had in 70s and 60s, you have increased bone stress in the micro threaded implants. Now, when there is increased bone stress, we found better attachment, less peri-implantitis and micro leakage. Few common, systems which use different kinds of thread designs. You have Brennemark system using V thread. You have BioHorizon using square thread, strawman buttress. Reverse buttress stress is seen in novel replace, square thread in Adine, and buttress thread in Genesis, and cylindrical and press fit in Zimmer. So this is just how, the various companies are using the kinds of, and we will discuss how the pros and cons of each. Before we move further, I would like to tell you that we are going to talk about osseointegration, material science, and of course the surface treatments as related to them. A small introduction, just a line to build up the link on osseointegration. I'm sure all of you are well aware of what is osseointegration today. The clinical success of an implant is based on osseointegration. The bone to implant contact at microscopic level is actually what is osseointegration. The surface treatment that we do, which are the various, whether it is, a macro surface treatment, a micro surface treatment, or a nano surface treatment, whatever type of surface treatment we do on an implant surface, it's basically increases the surface energy. It improves the osseointegration through wettability, cell proliferation, and growth factors that are related to it. A small video I'll be showing you on how exactly osseointegration does, and then we will move on to more advanced discussions. Surface treatment, this is a brief history. We had the surface treatment of titanium are directly related to their composition and roughness. Moderate surfaces show stronger bone responses. The surface modifications generally seen, type of implant surface, you have smooth, minimally smooth, moderately smooth, and of course the totally rough surface, ranging in a scale of zero point 0.5, that is less than zero point 0.5 microns to greater than 2 microns. This is how you could probably classify the surface modifications in implants. Of course, Brennemark gave the phenomenon of osseointegration. Then we had D. Groot giving us, plasma sprayed implants, which is a surface treatment, and where we also understood that osseointegration and enhanced by chemical etching and of the titanium implants. This is a brief history. Dual acid technique in dental implants, successful anodized implants, and of course, this is how the surface treatments were coming out from 1984 to 2003, how the treatments have been going on. See, the apparent attachment of correction of osseous tissue to an inert alloplastic material without intervening fibrous connective tissue. Before Brennemark, we had Linko and other people who were working and researchers, wherein they used to get the implants were put even before Brennemark. And, that time they used to get an intervening fibrous connective tissue. And of course, one of the predominant conditions was the kind of surgery defined by Dr. Brennemark and the loading protocols. So a small video to show you what exactly happens in osseointegration, because all these steps that are happening are actually affected when we do by surface treatment. At each and every stage, some type of surface treatment is enhancing this kind of osseointegration. So that was a small introduction to bio osseointegration, where we wanted to basically show you how the cells and the vascular network is being formed over a period of weeks. Now you see surface treatments we are going to discuss are going to enhance the mesenchymal cells, the osteoclasts, the osteoblasts at every basic level. So that is a brief introduction. Now implant surface treatments can be, basically the biomaterial used and the surface modifications. Commercially pure titanium was used earlier, and today we are using titanium with 6% aluminum and 4% vanadium. There's an alloy, and this is again basically because we realized that titanium osseointegration, even with pure titanium or alloy, is generally the same, but we needed more strength to get an internal hex into the fixture. So that is why an alloy system came out. But anyway, there are many factors to it. We move on to basically the advantages of Ti6Al4V and its excellent biocompatibility, corrosion resistance, high strength, relatively low modulus of elasticity, and good formulability, machinability, promoting osseointegration. Now, each is a topic by itself. There's just a small brief linking of the topic, and the surface treatments that we have. What exactly does it do? Any surface treatment accelerates osteoblastic adhesion and proliferation. I'll show you videos how it does it. It increases its bioactivity. Surface energy, bioactivity produces beneficial surface compressive residual stresses. Higher surface energy, which induces chemical and physical activities at an enhanced rate. It enhances fatigue strength, fatigue life due to compressive residual stresses, and it increases the effective function area by increasing the surface area of the implant. So the roughness. Now what happens when we create a rough surface on an implant, which I told you can be from, less than zero point 0.5 microns to greater than 2 microns. Enhanced platelet attachment, increased fibrin clot adhesions, improved implant tissue interface, affects the differentiation response to biological mediators. It inhibits cells from spreading but enhances differentiation. And most important, though at the last, it's high wettability. More hydrophilic, the more our tissues, because we are basically all of us, the whole body is composed of mainly fluids. So even the wound healing takes place by a lot of fluid interaction and vascularity. So looking at the classification of surface roughness of implants, you have macro level, micro level, and nano level. Macroscopic is your thread designs, which provide mechanical interlock and primary stability. They do not influence cell behavior or biological stability. However, these changes are related to implant design, like the screw shape, the thread, etc., where we talked about the depth of the thread, the pitch of the thread, the width of the thread, and of course the lead of the thread. So these are the macro level things. So again, helix angle, thread pitch, etc., which we have seen the inner diameter and the outer diameter. So the gross anatomy is the macro level. Like I mentioned earlier, we have standard V-shape, square thread, and buttress thread. We also mentioned which particular system is incorporating most of these types of threads. Then, of course, I also explained to you the 1-star thread and the 4-star thread. Now, this is all under the macroscopic. So, force distribution according to the thread design. Now, how exactly does this thread design really influence? You see, long time back, Wolf discovered there's a direct relationship with increasing mechanical load. You see, the areas where you have more stress, you have, but not pathologic stress. You have physiologic stress, the bone forms. The area where there is no stress, there is disuse, you have bone resorption. So these threads actually, we think that they are there to retain, but actually they are a form of type of forces that we generally exert through the implant into the bone. Now you see, I will come back to the slide again. You see, bones generally have a very good aptitude to take high compressive strength, about 170 MPa. They take poor tensile strength and very low shear stress, which if you saw even 1995 when we do the study, we found that horizontal stresses are not taken because it can't take the tensile strength or the shear stress. So these are the types of forces that you see: compression, tension, rotation, shear, bending, etc. Now coming back to the slide which I missed, shearing forces that you see generally are horizontal forces which when you apply, they create a bending force. So if there's a fracture, so this is the actual meaning of a shear force, that when you give a parallel force along the long axis of the body. Now let's look at a V-shaped thread. You see the white arrows show you tension. The black arrows are showing you, vertical black arrows are showing you the compression, and the tilted ones are showing you shear. So if you look at a implant thread which is V-shaped, you have a type of the stresses on the thread is generally depicted here. Now they are actually not really, I would say, very favorable for implants, but it is also subjective to the size of the implant and the kind of bone you're using. So, and see, very important over here, friends, I would like to say, we are not promoting any system, we are not promoting any manufacturer, and it's a disclaimer. We are just discussing on an academic front what exactly is going on. So there will be videos because naturally they have been made by the manufacturers, but it is by no manner that I'm trying to promote anybody or any company. So with that, I just move ahead a little bit. This is a buttress thread. They are non-symmetrical. They are very efficient in transmitting forces in a single direction along the axis of the screw thread. Now, the square thread, they are very good, and they have a symmetry on both sides, and they are perpendicular to the screw axis, and they are also very efficient in transmitting forces in both directions along the long axis of the screw. Let's take a look at the implant. This is roughly a hybrid implant, but you can see that there is a moderately rough surface due to some type of surface treatment, which we will not talk now, and the machine surface. This is basically to tell you what is a machined implant and what is a surface treated implant. So one half you seeing is a machine, and the other side is a moderately rough surface. When we do surface treatment or surface coatings, on a microscopic level, we create a very rough surface which somehow appears like this. But it's fantastic for osteoblast and osteoclast to come to resolve the unwanted things and of course to deposit bone. It has been clearly proved by many studies that whatever we do, a rough surface, even a cementum, where or the surface of the tooth where you have the periodontal ligaments attaching, it is rough. It is not a smooth surface. So surface treatments commonly used in titanium dental implants are your sandblasting, acid etching, and acid etching, hydrothermal hot pressing, chemical vapor deposition, ion implantation, laser pulse, dip coating, plasma coating. So micro level, coming back to from macro to micro. Any surface that is treated between 1 to 10 micrometers on the surface, any defect created or irregularity created is called micro level. To give you a better understanding, the thickness of a hair on the head is roughly 20 microns. Okay, so 1 to 10 micrometers is the surface treatment that we are talking about. Osteogenic cells respond positively to chemical and morphologic changes at nanoscale on the surfaces. So what are the implant surface modifications? You can have chemical, biological, subtractive, additive, all combined. And the subtractive process where you remove a layer from the surface of the implant of a particular thickness. You have grit blasting, acid etching, electropolishing, mechanical polishing, laser, microtexing. In additive procedures, you have something layered onto the surface of the implant, which can be around 20 microns, 40 microns, 15 microns. And that is titanium plasma sprayed, hydroxyapatite, calcium phosphate, anodic oxidation, ionic deposition, and electrophoresis. Biological, you have growth factors, peptides, and calcium phosphates, which you can dip, you can add, and whether you're using PRP or PRF, these are biological factors, which some of us also do it in our clinics. So electrophoretic deposition, you have a cell where you put an anode and a cathode. I won't go more into it, and a deposition takes place. Acid etching, most commonly used, SLA, acid etching, and your treatment with sandblasting. So immersing it in strong acids, that is nitric oxide, hydrofluoric, etc., or the mixtures where a micro thickness of 0.5 to 3 microns is created. On the right side, you can see a 1 micron surface created. The surface is pitted, removal of grain boundaries of the implant surface. This is on, again, microscopic level that you'll see the surface of the implant. And a small video again to show you how some types of acid etching is done.
Preclinical studies on surfaces, including moderate surface roughness, have shown stronger bone response as compared to smoother, turned, or rougher plasma sprayed surfaces. Dual acid-etched micron topography features have been shown to support osteoconduction mechanisms, including the promotion of fibrin blood clot retention and modulation of platelet activity. The discrete crystalline deposition of calcium phosphate nanoparticles establishes a bone bonding surface. In a preclinical study, The Biomet 3i T3 implant with the DCD surface demonstrated increased integration strength throughout the healing phase compared to less complex surface topographies. The 3i T3 implant utilizes the proven osteotight surface technology at the coronal aspect of the implant. 3i T3 implants are held to rigorous tolerances to provide a closely integrated implant to osteotomy fit, creating a dental implant system that helps achieve primary stability. The T3 implant is designed to reduce micro leakage through exacting interface tolerances and maximized clamping forces. Preclinical.
Coming to thermal treatment, heating the implant at a very high temperature creates an oxide layer. Again, you have a surface topography of, where it creates a roughness. You also have, now coming to plasma sprayed surfaces, you spray the plasma at a very high temperature and you get a 20 or a 30 micrometer thickness, which generally 40 to 50 micrometers to get it uniform. So plasma sprayed implants are also there in the market. And we have also a small video to show you how plasma, this is an SEM study. And again, just have a look at how plasma spraying is
It's
done.
important for the healing process after implantation that implants are wettable. We have investigated the wetting behavior of 2 titanium implants before and after plasma treatment.
You see, most important, please, he said, see the wettability, and he's going to demonstrate to you how hydrophilicity is increased by doing plasma treatment.
To demonstrate the effect, when applying the drop, we see that the untreated implant is hydrophobic. The implant wets poorly. The second implant is now treated with plasma. Due to the compact shape of the piezo brush, direct treatment is possible prior to operation or at the dental chair. Our test shows the wetting behavior has been significantly optimized. The surface is now hydrophilic. This optimizes and accelerates the implant healing, and the deposition of osteoblasts is faster and more extensive. The patient benefits from a faster and better healing process.
The next type of surface treatment is your sputter deposition, radio or magnetic. And atoms and molecules of a material are ejected in a vacuum chamber. You have a sputtering, you have over there a creation of a rough surface. Again, a small video to show you.
Sputtering deposition is done in a vacuum chamber. The most common substrate for the thin layers is glass. The sputter system can have different sizes depending on the application. The source of the thin film material is a planar or rotary sputtering target of metal, ceramic, or even plastic. Molybdenum targets, for example, are used to produce conductive thin films in displays or thin film solar cells. At this point, the process starts. Air is continuously removed by vacuum pumps. The base pressure in the vacuum is around 10 to the minus 6 millibar, which equals about a billionth of the atmospheric pressure. Argon gas is introduced continuously to achieve a low-pressure argon atmosphere. A magnet array inside the cylindrical target generates a magnetic field. The target is filled with cooling water, which will dissipate the heat generated during the sputtering process. The targets are rotating so that the material will be utilized uniformly. A high voltage is applied to the molybdenum target and creates a plasma, which is concentrated along the magnetic field. The plasma consists of argon atoms, positively charged argon ions, and free electrons. Positively charged argon ions are continuously generated by electrons hitting the argon atoms. The sputtering target is negatively charged. Therefore, the argon ions are attracted towards its surface. Let's see what happens. The argon ions collide with the target and eject molybdenum atoms from its surface. This is what the sputtering process is all about.
Okay, that was nice. Now coming back to biomimetic deposition, you have hydroxyapatite, sorry, and calcium phosphate on the surface, which basically implant materials in a simulated body fluid. So calcium phosphate coatings and hydroxyapatite in the thickness of 20 to 25 micrometers is placed. You again have a created surface, rough surface, small video to show you the coating of calcium phosphate on an implant surface. You have high pressure and temperature. That's what the bar was showing. This attracts the calcium phosphate ions and molecules onto the implant surface, and this is how the deposition takes place. Grid blasting. The surface of an implant is bombarded with hard, dry particles or particles suspended in liquid through a nozzle at high velocity by means of compressed air. And you have different types of materials, ceramic particles, glass, silica, aluminum. The problem is that if the implant is soft and it's not a strong alloy, you can have sometimes contamination of these particles remaining onto the surface and getting embedded into the implant surface. So a small video for you to see how grid blasting is done.
Need to be blasted. It's because it's necessary to have the right surface roughness for bone to implant implants. It's possible to blast implants with different materials, such as titanium oxide, aluminium oxide, silicon oxide, and calcium oxide. Most commonly used is aluminium oxide, although some manufacturers prefer to use titanium in order to have no contamination. However, by having the right production process, also other materials can be used and guarantee no contamination. After machining and degreasing, implant goes for samples, and then for acid etching, ultrasonic bath, and heat. If it's not blasted on the precise roughness, finished implants after acid etching will not meet requirements, so it's important to have stable and repeatable process of sandblasting. Here at Bhargava, we designed a fully automatic machine for surface treatment of implants. It's called Dental Blast 900, and it's one of the most advanced machines for surface preparation of dental implants on the world. To control stream from the nozzle, we developed a suction-type blasting guns with measurement system for negative pressure. After implant is loaded onto satellite, turntable rotates to the blasting area where it's being blasted with suction blasting system for approximately 15 seconds while the implant is being worked. This assures perfect coverage on complete implant surface. After implant has been blasted, there's also cleaning cycle where implant is cleaned with care. You know,
So since time is short, we will move on. There are a lot more that I have to share with you. Nanotopography, nanotechnology has received a wide attention in public and scientific media. Okay, and you can small is good now. Today the saying is, and it has been hypothesized that the osteoconductivity of micro and nanoscale implant surfaces influences the osteoblast. See, whether it's a nano surface, micro surface, macro surface, at the end of the day, we are all trying to enhance the osteo conductive activities and osseointegration. So a video here to show you how nano surface is achieved. I'll just take a minute to explain to you in this video what we are trying to show is that it has been proved by a lot of researchers that a particular kind of mesh that is created due to the nano surface treatment, that particular mesh enhances and captures the fibroblasts and the mesenchymal cells and enhances osseointegration. And they've seen that if this mesh is not there, you do not have the kind of healing or the osseointegration that would probably take place because of the presence of this mesh. Probably the mesh is like a scaffold over which all the cells adhere and grow. So discrete calcium and crystalline deposition. Generally in the Zimmer implant, you will see the DCP being used, biomet. Calcium phosphate particles 20 to 100 nanometers are deposited by double acid test technique on the surface. And it is proposed that 50% of the surface area and higher adhesive forces are generated. Laser ablation, proposed and being used by BioHorizons, and an excellent outcome, clinical outcome seen. The neck of the laser implant has been processed in a laser micro machining step to generate a pattern of micro and nanoscale microchannels. Let's have a small video to look at how the process is.
BioHorizons' revolutionary laser lock technology is a series of microscopic channels engineered onto the surface of BioHorizons implants and abutments using a pulsed excimer laser. These unique microchannels are optimally sized to control and organize fibroblasts, epithelial, and osteogenic cells. During the healing process, epithelial cells are guided into the precisely dimensioned microchannels and firmly attach pseudopodia to the complex nanostructure of the uniform laser lock surface. The guided cellular response generated by the laser lock.
The term is guided cellular response.
Technology continues with subsequent layers of epithelial cells, creating organized junctional epithelium successfully integrated onto the implant surface. As a result, epithelial downgrowth is inhibited. While the junctional epithelium is being created, fibroblasts migrate to the laser-locked surface apical to the epithelium, attach and secrete collagen fibrils that lock onto the laser-locked structure. This connection forms a robust, soft tissue seal. The attachment establishes a protective soft tissue layer around the implant that protects the crestal bone from bacteria and trauma. Once a stable soft tissue seal is created, osteogenic cells migrate along the implant surface and are directed into the laser lock microchannels where they attach and differentiate. Osteoblasts begin to form a circumferentially oriented bone microstructure with trabecular attachments parallel to the microgrooves. These structures mineralize during normal healing. Bone formation around the laser lock surface has been shown to result in greater bone to implant contact, faster osseointegration, and higher crestal bone levels than other implant surfaces. The inhibition of epithelial downgrowth, establishment of a soft tissue seal, and greater bone to implant contact created by the laser lock microchannels maintains function and aesthetics long term.
Anodic oxidation, another form of surface treatment. Generally, in the noble implants, you will find them. Titanium oxide layer from 17 to 200 nanometers in conventional implants, 600 to 1000 nanometers. This is a porous surface of microstructure with a pore size of 1.3 to 2 mm with a moderate degree of roughness is generated. So this is your anodic oxidation, titanium porous oxide. Again, let's have a look at a small video. They're adjusting the amount of voltage and current. There's a small piece of a piece of titanium inside the now this is the electrolysis going on. Have a look at the surface now. This is an anodized surface. Titanium oxide blasted and acid implant, dense-plied TO blast implants. This is another way of getting a surface treatment. So it's on a micro scale. You have two subtractive sequential manufacturing steps. With etching is done with hydrofluoric acid. Coming to something very interesting which has come out in the last probably decade, the sensitizing topic, which is photo functionalization. You know, fantastically, it has been seen that probably in the next slide, the titanium oxide is responsive to any visible light, which has a UV component. And this is called as the Honda Fujishima effect. Whenever UV light falls onto the implant, titanium implant, it enhances the bioactivity and osseointegration by altering the titanium oxide on the surface. You know, titanium, because of the oxide layer, we get osseointegration. So the UV light is believed to enhance the osteoconductivity. It reduces the degree of surface hydrocarbons, increases the surface energy and wettability. I'll show you a video on this. And it raises the level of protein absorption and cellular attachment to the implant. A very, very simple technique, which probably can be done chair side also. And you can see the fantastic results that we get. Now, you see, normally UV light is in the range of 10 to 400 nanometers. You have UVA, UVB, and UVC. And we are generally using the UVA light over here, where we use it for our bioactive titanium, increasing its bioactivity. Another point that probably we all don't know, or most of us are not aware, that there is a bioactive aging of titanium oxide within a short period of time of manufacturing. And this may be as short as 1 week. That means if your titanium implant has been manufactured more than a week old, it has started showing bioactive aging. Okay, so its surface is slowly deteriorating as far as we are concerned about its osseointegration potential. Okay, so titanium oxide in a common tetragonal form, the crystalline aneurysm can be bioactively reactivated by a photocatalyst such as UV or visible light. The surface energy creates an oxidative potential that converts water to hydrogen and oxygen. Visible light may induce an electric current in the titanium nanoparticle. This activated titanium oxide can act as a catalyst to split the proline and amino acid units, creating a bioactive locus. So basically, it causes radiation causes succinyl amide ester bond to be formed. between a protein and hydroxyl. I'll give you a schematic diagram where basically it induces the electrostatic stage, it induces the hydrocarbons and the proteins to form. Yeah, here it is. So you have an edge surface of the titanium, you put UV light and you increase its hydrophilicity. Now see, if hydrophilicity is not there, blood is not going to come close, blood is not going to come close, it's going to delay your healing. Electrostatic status, by increasing the ion attraction and polarization on the sides, you have deposition taking place of your bone. Hydrocarbons, of course, because body is composed of hydrocarbons, so it also affects this. Now, let's see a small video on how hydrophilicity is increased. Now, this is the titanium which has been UV treated. So that was on how the three factors of electrostatic, hydrocarbons, and your wettability is increased when we do UV treatment. Yes, Ruben. Okay. So hydroxyapatite is stable in a biological form. Calcium phosphate strengthens the organic matrix by mineralization. It generates hydrophilicity. Nanotechnology also plays an important role to compose the hydroxyapatite crystals. It is used as a single compound coating on the implant surface. Let me show you hydroxyapatite coating in a little bit super fast mode. The implant is dipped, taken out, and again you can see that increases the hydrophilicity. Your temperature treatment for all the implants so that the coating gets well sintered and attached. And finally, the rough surface that you achieve. Growth factors that you can add. BM2 contains biomimetic calcium, phosphate, growth factors, fibroblast growth factors, and platelet-derived growth factors. They are also added onto the implant surface by various agencies and manufacturers. And of course, they increase the cellular level osteoprogenitor cells, your osteoblasts, osteocytes, molecular level, the minerals, hormones, growth factors, cytokines, and your extracellular matrix proteins, which get attracted due to the chemical nature of the particular growth factor that you've added. So if you want to promote the bone implant regeneration, you have surface coatings of calcium phosphate, bioglass, collagen 1, growth factors, and many other drugs. This is a schematic diagram, and this is a small video again. I will just show you briefly. This is how you're adding the growth factor, probably PRF, PRP. You can coat the surface of the implant and place it onto your osteotomy site. Coming to a small overview, what exactly is generally the surface treatment that is happening, to summarize in a manner, the types of surface treatment seen in the market. You have your acid etched. Generally, the implant system uses your Biomet or Zimmer. Rationale is that the surface with the micrometer scale roughness increases total surface area. The limitations are that it is a possible contamination. Other surface treatment is your anodized. It's a electrochemical process. I've discussed it already. You have Noble Biocare, Tri-Unite, maintains implant stability at critical healing phases. That's the rationale. And the limitations are that it has shown resolution of peri-implant pathology. Now, this is what the literature says, which I'm sharing with you. Of course, I don't have an experience of all the systems, but yes, to a certain extent, large systems, we have an experience, and you have the surface treatment, which is blasted. So you have Dentsply, Astratech, Tibla, Zimmer, and inclusive of these, your tapered implants. The rationale is the surface area is increased. Of course, all surface treatments increase surface area by 60% and hydrophilicity, and of course, the attraction of the enzymes which create your osteogenesis. So particle contamination is common, which I already mentioned earlier. You have blasted and acid etched, which are your, again, Fiolate and Trident, commonly system implants, and rationale is, again, contamination is less when they talk about them, and the remnants of particles are present, but particles are generally washed away with a particular treatment that they do. So hydroxyapatite, the only problem is that decomposition of hydroxyapatite. And of course, some studies have also said about the osteogenic potential compared to other factors. But since it was one of the most earlier started treatments, it still is there. And you also had reported in the literature the chipping of hydroxyapatite layer from the surface of the implant when you are torquing it in. So laser ablation and plasma spread. BioHorizons, I told you, uses the laser ablation, and Strawman uses the plasma spread. You have the rationale is controlled cellular migration, and of course microchanneling. The basic, what we say is the claimed by BioHorizons, the saucerization that does not occur or the crestal bone loss is because of the microchannels. So plasma spread coating increases the surface area and cell bioactivity. You have decomposition and ACP formation and cracking, again, like I told you. So just to briefly bring to a small conclusion, what we exactly are discussing, what we are doing is that, you see, if commonly seen is this kind of a saucerization that you see in your implants, probably over a period of time. Now, this could be due to various reasons. And the reasons can be, like a type of surgery, a host factor, the type of abutment, etc., etc. But and of course, loading, no doubt, which I also covered in my last topic. But what I'm trying to say here is that we do not understand, or we do not give importance to the type of implant we are using. If you use a surface treated implant, this is a case that I'm going to show you, which is, a combination of everything, implants, your implants attached to natural teeth, sinus lift, bridges. It's an 8-year follow-up, full mouth rehabilitation with 11 implants. And what I basically want to show is that you have no saucerization or you don't have any bone loss. Now you see, this is of course not my platform right now to talk on these clinical cases, but I'm just sharing with you that if you have a good, like you see here, this is a platform sharing, a platform switch. If you see that, and if you have micro threads, and you have the right kind of, threads that you have used, you get a beautiful bone to implant, and load is transmitted fantastically. So, you can avoid the type of the design you're using, the type of the coating you're using, the type of the surface that is there. It definitely plays a long role in your success of implantology. If I show you a magnified view, again, there is no bone loss. This is of course now more than 12 years or whatever. So idea of this topic or discussion is that we place a lot of emphasis basically on how to do an implant surgery and the processes, but my objective is also to bring to you the third dimension, and that is the type of implant, the kind of implant, the surface treatment of the implant. So originally crest module was always smooth and polished. Use of a smooth neck on an implant was incorporated to increase the plaque retention, because in majority the implant's coronal portion was not embedded in bone. Now this is how, over a period, one particular surface or design that has been changed, which I'm discussing with you. Now you had smooth collars and now you have threaded implants. So when the smooth portion of an implant was placed under the bone crest, it resulted in crestal bone loss due to shear forces and eventually pocket formation. We spoke about shear, we spoke about loading, we spoke about the type of treatment. Recently, the concept of microthreads in the crestal bone has been introduced to maintain marginal bone and soft tissues around the implants. Some authors attribute this to loss of disuse atrophy. In the presence of smooth neck, negligible forces are transmitted to the marginal bone, leading to the result. This is just a thought for you to think that how the shape is making the change in a particular neck, which is the most concentrated area where you see saucerization. So final remarks, I will skip this because we've already discussed the trends. We have nanotechnology coming up in a big way. This is going to be the future. You have hydrogel, titanium nanotubes, etc. What it does, fibroblast, human epithelial cells. This is going to be the trend in future, where you're going to see proteins and other cellular, enzymes playing a big role onto the enhancement of osseointegration in the mechanical and chemical interlocking of the osseointegration and bone to implant contacts. Sclerostin is a messenger molecule that mediates the osteoclast interaction. It is secreted by osteocytes and inhibits osteoblastic activity. So now as we are progressing where we want probably not 3 months of osseointegration, we want shorter and shorter periods. Probably these are the treatments which in future, whether it's fluoride or whatever, I can only say that implantology is a dynamic field. We continue to think, rethink, and revolve. A lot of old concepts are challenged and new ideas keep stimulating us. And let us remember that change is the law of nature. I will not go into more gyan. I will just probably like to thank that this wonderful presentation was only possible because of the effort in collecting the videos and the data. And I sincerely thank Dr. Priyanka Thukral, our professor in Santosh Dental College. All our prosthodontists here, and she did an excellent job in collecting the data and the video. Of course, Dr. Abhishek Nagpal, under whose probably supervision this all the presentation was made, and Rick, an upcoming good postgraduate student, seems to have a lot of probably promise in him. So thank you all, my friends, for this wonderful hearing. And I hope I have been able to give you an offshoot insight into the basic nature of surface treatment and its role in osseointegration. Thank you very much.
The question and answer session. Is RBM implant surface the best? Is there any expiry date of an implant?
Sir, expiry date, even if you look at your water bottle that comes, even that has an expiry date. Okay, even water has an expiry date. So everything has an expiry date and it is there. Generally, the expiry date is 5 years to 10 years, depending on the kind of treatment. Now, whether RBM is good or not, well, see, I've completed everything. Now, whether it's a blast media, RBM basically, whether you use grit or whatever, it's, I would say, as long as the surface that you want to create is hydrophilic, rough to an extent that it attracts the kind of osteoblasts and all, it is good enough. But to say which is the best and which is not, I would not say, because that would be going, and probably saying something which others are doing not correct. But yes, micro-threaded, SLA treated, and let's say non-smooth implants, I would say, with platform stitching are the what we require at the end of the day.